This is also being recorded and will be posted on my website shortly. So we'll start with the basic question, what causes weight gain? The answer, of course, is more calories intake than calories expended. Dr. Friedman, that's not why I joined the webinar. So we'll get into a little bit more specifics about that. And I think, as many people know, that's not the only answer. Correct. So weight balance is a complex process that depends on hormones, other medical conditions, sleep, stress, mood, and the motivation to stick to lifestyle changes. Which hormones cause weight gain? The most important one that I'm going to be talking about mostly today is high cortisol. High cortisol is associated with stress. Cortisol is a stress hormone, and also with the disease called Cushing syndrome, which I will also talk about tonight. Low thyroid hormones, hypothyroidism, can give weight gain. Low growth hormone controls a hormone called IGF-1. High insulin, low hormone leptin, and low testosterone, low estrogen, and low oxytocin. I put the two at the bottom because they're a little less concretely proven to be controlling weight. How does cortisol lead to weight gain? High cortisol levels leads to visceral or central obesity. Nighttime cortisol may specifically be more detrimental than daytime cortisol. Cortisol normally has a circadian rhythm that it's produced mainly in the morning. It goes up a little bit after meals, and at nighttime it's supposed to be quite low, but in conditions of either Cushing syndrome or other diseases, the nighttime cortisol may be quite detrimental. Most studies suggest that it increases appetite, but I'm not really that sure because most of my Cushing's patients don't eat that much. And it may affect the type of food eaten, especially comfort foods. How does cortisol lead to weight gain? Cortisol stimulates a hormone called lipoprotein lipase, or LPL, and inhibits a hormone called hormone-sensitive lipase, HSL. These are enzymes involved in fat storage. These enzymes are mainly in visceral fat, which is why cortisol leads to weight gain there. Cortisol and insulin leads to storage of triglycerides and increased breakdown of, and increased accumulation of fat. Cortisol leads to larger fat cells. The adipocytes are larger. Growth hormone, testosterone, and to a lesser extent estradiol act oppositely to the combination of cortisol, and they stimulate fat breakdown. So cortisol and insulin leads to increased fat accumulation, and growth hormone, testosterone, and estradiol leads to fat breakdown. How does cortisol lead to weight gain? Cortisol, either from stress or from Cushing syndrome, inhibits the thyroid, growth hormone, and reproductive axis. And these axes are important in abdominal fat breakdown. So you have less abdominal fat breakdown because the thyroid, growth hormone, and reproductive axes are less. Cortisol stimulates glucose production, which leads to more fat. Cortisol increases a hormone called NPY, neuropeptide Y, which is a brain appetite hormone. And how does the nighttime weight gain, the nighttime high cortisol lead to weight gain? Because people don't necessarily eat when they're asleep or at night. And I think that's an interesting question that I don't think we know the answer to. But I put patients on the medicine called ketoconazole. I put them on it at night, and they seem to lose weight. So lowering the cortisol at night does somehow affect the effects of cortisol on daytime food intake and appetite. Cortisol also decreases muscle strength, making it harder to exercise. High cortisol leads to fatigue by unknown mechanisms. High cortisol leads to poor sleep, which leads to weight gain, and it probably changes food preference to comfort foods, high-fat foods, and sugary foods. Comfort foods are things your mother used to make, like macaroni and cheese and mashed potatoes. And when people have poor sleep and high cortisol, they don't really crave carrots or tomatoes. They usually crave the comfort foods that we talked about. Poor sleep leads to high cortisol, and stressed is dessert spelled backwards. Hard to avoid stress, it is better to learn how to deal with it better. How does insulin lead to weight gain? Cortisol increases insulin, and insulin facilitates the conversion of energy into fat. Insulin is the rainy day fat storage hormone, and that leads to weight gain. When insulin levels drop, the body starts to burn fat and weight loss occurs. Normally, leptin, the hormone made in your fat cells, tells your body to make less insulin, so don't store fat. However, in obesity and Cushing syndrome, the leptin doesn't turn off the insulin, so you keep on converting energy to fat. High insulin blocks leptin, you feel hungry even when you're full. And insulin resistance, which occurs in people that are overweight, their insulin doesn't bind to the receptor properly and doesn't signal downstream properly, and you fail to sense that you're full. You also get more brain dopamine release when you eat, so you get what's called more reward. You feel better after eating comfort foods than if you didn't have the high insulin levels. And it's a way to look at it, you become more addicted to food. High glycemic foods leads to release of insulin, and eating high fiber helps prevent the release of insulin. There's a drug called metformin that can lower your insulin levels and also may be effective in some of the effects of insulin on weight gain. How does leptin lead to weight gain? Leptin is made in fat cells. The more fat cells you have, the higher your leptin. High leptin tells you not to eat anymore. Low leptin tells you to eat more. But most obese people, even though they have high leptin, they're leptin resistant. The leptin doesn't work properly, so you still eat even if you're full. And if you're leptin resistant, both starvation and reward signals occur, and it makes it especially hard to lose weight. So what do you do if you have high cortisol and are insulin and leptin resistant? Certainly you can exercise, although exercise raises cortisol acutely at lower cortisol levels later in the day. Exercise prevents insulin resistance and improves clearance of fat from the liver. It allows, so that's the reason to exercise. You should try to deal with or reduce your stress. And carbohydrates stimulate insulin release, so you're better off on a low-carb, low-glycemic diet. Thyroid hormone. Thyroid hormones play a crucial role in metabolism. Hypothyroid patients have a slower metabolism. They're also more tired, they have fluid retention, and have a harder time to exercise. In hypothyroidism, the liver doesn't work as well to metabolize glucose. Hypothyroid can lead to weight gain, but it's usually modest. Hashimoto's hypothyroidism is an autoimmune disease with positive TPO antibodies. Patients with Hashimoto's and also patients that had their thyroid removed by surgery or radioactive iodine, they usually have more weight gain than the people that have other types of hypothyroidism. However, patients with hyperthyroidism have increased appetite, so I don't recommend using thyroid hormone for weight loss in somebody with normal thyroid tests. Growth hormone. Growth hormone is made in the pituitary and goes to the liver to make and release the hormone called IGF-1. Growth hormone itself can lead to diabetes and insulin resistance, but IGF-1 is the active hormone and in general increases metabolism. IGF-1 decreases fat stores and leads to increased muscle mass. In patients with normal IGF-1 levels who are not growth hormone deficient, growth hormone has minimal effects on weight and probably increases the risk of cancer. So I don't really recommend treating people with normal IGF-1 levels with growth hormone. However, in patients that are growth hormone deficient, and we confirm that by doing a growth hormone stimulation test, growth hormone treatment leads to increased energy, increased muscle mass, better sleep, decreased abdominal weight, and eventually weight loss. There is a supplement called Serovital that's a supplement of amino acids that stimulates at the hypothalamic level GHRH, which leads to more growth hormone and more IGF-1. And that would be an option for patients with low IGF-1 who are not growth hormone deficient, and they may benefit from the supplement called Serovital. Now, testosterone is important. In both men and women with low testosterone, testosterone replacement increases muscle mass and decreases abdominal fat. It also blocks some of the detrimental effects of cortisol and fat. It's not recommended in men and women with normal testosterone levels, however. Estrogen is also an important hormone. weight gain is common in perimenopausal and menopausal women, and it may be related to worsening mood and poor sleep. Low estrogen may lead to fat storage, and estrogen replacement is often beneficial in perimenopausal and menopausal women. The hormone oxytocin is made by the posterior pituitary like AVP. It's the only prominent pituitary hormone that's not tested or replaced. It may have a role in bonding, intimacy, orgasm, GI issues, trust, generosity, pain, and energy. In 2015, there was an Endocrine Society abstract that showed that oxytocin led to weight loss in men, and it needs to be studied more, but I'm measuring it in a 24-hour urine assay and treating those with hypopituitarism and low urine oxytocin, and some of my patients seem to be losing weight. And why is it so hard to lose weight? And I hate to say this, but most people do gain weight as they age. There's something called the thrifty gene hypothesis. Humans have lived for millions of years in times of scarcity, and therefore hormones such as leptin, insulin, and cortisol have evolved to prevent starvation. In times of starvation, the hormones of the thyroid, reproductive, and GI axis are shut down. So now we have food that's abundant, but we still have our hormones that are designed to prevent starvation. And this is one of the reasons hormonally why it's so hard to lose weight. Also, there's abundance of high caloric, unhealthy foods available. Most of these are low cost, while the healthier foods are more expensive. There's less time to exercise. People have sedentary lifestyles. People don't get enough sleep. They're surrounded by electronic LCDs that keep them awake at night, and people are under a large amount of stress. So who should see me for if they're having weight gain or can't lose weight in hormonal testing? If you have unexpected weight gain, you're on the same diet and exercise pattern, all of a sudden you gain a lot of weight. If you have rather dramatic weight gain over a short period of time, so if you gain about 50 pounds in a year, you're more likely to have a hormonal problem than if you've gained a pound a year for the last 20 years. Other symptoms include fatigue, irregular periods in a premenopausal woman, or hair loss might be a sign that you should see an endocrinologist like myself. What will I test for to see if you have a hormonal cause of weight gain? Cushing syndrome, growth hormone deficiency, hypothyroidism, testosterone deficiency, estrogen deficiency, hypopituitarism, iron deficiency, because the iron deficiency patients are often fatigued and they may have weight gain from that, vitamin D deficiency, insulin resistance, and a condition called polycystic ovarian syndrome, which is high testosterone and insulin resistance, and these patients often have a harder time losing weight. So I'll highlight a few of these symptoms. First of all, Cushing syndrome. In Cushing syndrome, you have the most amount of weight gain. You usually have rapid weight gain. However, I've seen patients that haven't gained much weight and are reasonably thin, and that's because they've done a great diet and they exercise vigorously. Cushing syndrome has poor sleep, fatigue, central obesity. Most of their weight is in their abdomen. They have a buffalo hump, stretch marks, acne, extra hair growth, a round red face, bruising and thin skin, and poor muscle strength. In Cushing syndrome, we test for nighttime salivary cortisols. In Cushing syndrome, the circadian rhythm is also, you have high nighttime cortisol and lower normal daytime cortisol. We test for 24-hour urines for urinary-free cortisol and the cortisol metabolite, 7-10 drugs and steroids. We do a 10-hour urine for urinary-free cortisol creatinine ratios. We do a nighttime serum cortisols. We look for MRI to see if they have a pituitary tumor. And the best treatment for Cushing syndrome is surgery, usually a pituitary surgery if they have pituitary Cushing's. However, there's a medicine that's used for, it's officially used for fungal infections, but it's an excellent medicine for Cushing syndrome called ketoconazole, and I often use that as well. Are there supplements to take for lowering cortisol? Yes, you can take these, especially at night. When you want to take them at night when cortisol is inappropriately high, you can take a supplement called phosphatidylserine, 300 milligrams, ginkgo biloba, 120 milligrams, or DHEA, 25 milligrams in women and 50 milligrams in men. All these you can get on Amazon and they're readily available. For growth hormone deficiency, I screen with hormone the IGF-1. If it's in the top 75% of the normal range for the age and sex, such as greater than 150 nanograms per mil, growth hormone deficiency is less likely. If a patient has a history of empty-sella, a history of head trauma, headaches, and low blood pressure after delivery, Sheehan syndrome, a history of pituitary surgery or radiation, or a pituitary tumor, micro or macroadenomas, growth hormone deficiency is more likely. And if the IGF-1 is less than 75, growth hormone deficiency is likely. We then do a stimulation test. I usually do the glucagon stimulation test. What the cutoff should be is unclear, but a reasonable cutoff is 5. If your peak is less than 5, then you're considered growth hormone deficient. And I give growth hormone if you fail your stimulation test. And at times we can use the supplement Sterovital if you pass your stimulation test. So what can a patient do to lose weight on their own? I recommend the low or no carbohydrate diet with some lean protein and mostly vegetable diet. People call us can call us a paleo diet. Really try to push the vegetables. Avoid processed foods and simple carbohydrates. Get an app and track your food intake. Many people eat more than they expect. I would say 1,200 to 1,400 calories for women and 1,400 to 1,600 calories for men is a reasonable guide. Try to avoid eating at night and avoid stress eating. What else can you do to lose weight? Exercise 30 minutes, 60 minutes a day. You can try to do it longer if you can. Eat a high fiber, low glycemic diet. Get at least 7 to 8 hours of sleep at night and avoid and learn how to deal with stress. Again, it's often hard to avoid stress, but at least learn how to deal with it so you don't take it out on eating more foods. Okay, I think that concludes the formal part of the presentation. We will open it up to questions using the chat button. Keep the questions related to the topic, one per person until everyone asks one, then we can go back around and try to keep them general and not personal. My website is goodhormonehealth.com. You can schedule an appointment on that, and I will be posting the webinar in a few days. Okay, does anyone want to have a chat? Want to ask a question by chat? Okay, so Judith asked, why is testosterone estrogen replacement no longer necessary for women? And I would say testosterone estrogen replacement is necessary for women, for most women. At some age, the risk outweigh the benefits for estrogen replacement. The famous study, the Women's Health Initiative, looked at women in their 60s, and at that time there wasn't a clear-cut benefit of estrogen replacement, and they had more incidence of heart disease, strokes, cancers, and blood clots. However, if the data was looked at around the 40s or 50s, the estrogen replacement was beneficial and the risks were minimal. So I would say, in general, testosterone estrogen replacement is necessary, certainly for the patients that are low in it. Frederick asks, what thyroid levels do you want? I want people to be euthyroid, and for patients with a thyroid problem, that would be the TSH would be normalized, probably between 0.5 and 2. We want the free T3 and the free T4 to be in the normal range as well. Again, patients that don't have thyroid disease don't benefit usually from thyroid medicine. I don't recommend that. Patients with a TPO antibody are more likely to have true hypothyroidism, and I would treat them at a lower TSH than other people. Alicia asked, what are the effects of mast cell activation on cortisol levels? I'm afraid I don't really know that answer, so I'll have to pass on that. Other questions? Kelly asked, is it normal to have a sudden 5-pound weight gain overnight after 2 to 4 weeks after each and every medicine change? People do have some trouble usually adjusting to medications. I'm not exactly sure why that would lead to weight gain. Some of it is probably some fluid retention, but you know, I guess if that's the case, you want to you know, try to minimize your medication changes and push your you know, try to push yourself more if you are having those weight gain, and try to figure out what the problem is. Frederick's question: what is the preferred drug for cortisol replacement? I would say the preferred drug is hydrocortisone. Hydrocortisone is actually cortisol. It's what the body makes. And I would start with the cortisol mostly in the morning, with less of it as the day wears on. Janet asked, if a menopausal woman who has been replacing estradiol, progesterone, and testosterone stops estradiol and progesterone, should she also stop testosterone? No. I think testosterone is a separate hormone that can often be given later than the estrogen and the progesterone. The estrogen and progesterone, we may stop at 60 or 65, but if the testosterone would be low without the testosterone level will be low, and the patient's benefiting from the testosterone, they can continue the testosterone without the estrogen and progesterone. Pat asked, can you give us a little more information about oxytocin? So I do have an article on my website about oxytocin. Oxytocin is made by the posterior pituitary along with a hormone called AVP, or arginine vasopressin. So patients that have problems with their AVP, and the disease they can get is called diabetes insipidus, are more likely to have problems with oxytocin. Patients that have had, you know, very extensive surgery or radiation to pituitary are also more likely to be oxytocin deficient. And oxytocin, I mentioned, is more likely to be involved in bonding, intimacy issues, but it seems to have some role in weight as well. So I do have my patients to get a 24-hour urine measured for oxytocin, and those that are low, I put on oxytocin. Some of them have had side effects from it or how it interacts with other hormones. Other of them have done quite well on it. Judith asked, I'm concerned about body fat. How dangerous is it? I've done everything you've suggested for healthy eating, exercise, but still have body fat. But belly fat. Belly fat is dangerous. So the fat in your abdomen is the most dangerous type of fat. It's called visceral fat. And fat is actually an endocrine organ. It makes hormones. It does make the hormone leptin. It makes inflammatory hormones. And in general, the patients with the higher body fat make these detrimental hormones that can lead to heart disease. So it is detrimental. You know, you may need to be tested for some of the conditions I talked about, and you know, you exercise and all those things really proportionally decrease your body fat. So it will help on belly fat, and it specifically helps, exercise specifically helps against things like fatty liver disease, where the abdominal fat seems to go to the liver and get stored. That seems to be helped by exercise. Judith asked, I have Sheehan's. How do I get rid of myself of my body fat? So in Sheehan's, you have hypopituitarism. Sheehan's happens after people deliver. Their pituitary gets bigger during pregnancy. It has like a mini infarct afterwards, and then it gets dysfunctional. And patients with Sheehan's syndrome needs to be treated with things like growth hormone and some thyroid medicine, testosterone, estrogen, and occasionally cortisol, and you need to be treated properly. So if someone's taking too much cortisol, for example, they can get abdominal fat, so you need to have all your hormones properly tuned up. Frederick asked, can you use Adderall and metformin together? I don't see why not. So metformin helps by helping decrease insulin resistance and decreasing the amount of glucose made by the liver. So it's helpful, very helpful for patients with prediabetes and is associated with a little bit of weight loss. Adderall is a stimulant that often gets people to have, you know, decrease their appetite and increases their metabolism, and it also gives people a little more energy. So that's a very reasonable combination. Adderall is a controlled substance, so you need to be monitored while taking it. Janet asked, I've heard that the Women's Health Initiative uses synthetic hormone Premarin and synthetic progesterone Provera. Are there any studies in Europe or the U.S. on bioidentical hormones? There are some studies, yes, that show much more beneficial effects than, as Janet pointed out, the synthetic hormones Premarin and progesterone. So I think when the Women's Health Initiative came out in 2003, there was a big rush to stop people on hormones. And now that there's these other studies coming out with bioidentical hormones, and especially women at a younger age, they're having much more positive effects. Is there any specific amino acids that's beneficial for low growth hormone? So arginine is used as an arginine stimulation test. So arginine is probably the one that acutely raises growth hormone. The products like Serovital, there used to be a product called transditropin. They have, several amino acids in them. I think that it's proprietary exactly what they are. So in general, I usually have people go to the Serovital website and order that. It doesn't need a prescription. Most of my patients find that it's better than the older one called D-transtropin. These definitely affect growth hormone acutely, but I think there are some effects of them chronically as well, that they do seem to raise your IGF-1. Judith asked, do you foresee oxytocin becoming a paid drug for Cushing syndrome insurance? Are there studies going on regarding oxytocin and its benefits? So I'm not really doing a study on it, because to do a study you need you need IRB approval, and you need what's called an IND. So you have to lobby the FDA to allow them to use oxytocin, and it's a rather lengthy process. The doctor that did the presentation at the Endocrine Society does have an IND for oxytocin. I did talk to her about collaborating, and we didn't get too far. So I think she is doing some studies on it, and I think, as more people do studies, there's a good chance that it will be approved, but I think this is many years down the road. Amy asked, are there beneficial supplements to help with carb or sugar cravings? So I think metformin helps with, it's not a supplement, it's a medicine. It helps with carbohydrate and sugar cravings. In general, also carbohydrate and sugar cravings can be due, first of all, they occur in people with depression. It's thought that it can be due to low serotonin levels in the brain. So things like 5-HTP may be helpful in terms of reducing your carb or sugar cravings if you don't have depression but want to try something like that. Frederick asks, is T3 monotherapy more effective in hypothyroidism? I would say no. The body makes both T4 and T3. If you take only T3, your T4 goes to 0. The T4 has a long half-life, and it's sort of like the reservoir, while the T3 gives you more specific boost maybe, but I like people to have both the T4 and T3 on board. Stephanie asks, what non-strenuous exercise would you recommend for a patient with high cortisol? So I think walking is a great non-strenuous exercise, and walking's been shown to lower cortisol. I really like the video from Kaiser Foundation, the Walking Revolution, that talks a lot about the sort of the beneficial effects of walking and how it can be used to combat obesity. My wife is a Pilates instructor, so I certainly have a bias for Pilates. I think it's great, great form of exercise. Yoga's excellent. Stretching's great. All those are really good choices. Susan asks, I can't seem to tolerate growth hormone well. Is Serovital instead of growth hormone? I think Serovital can be used instead of growth hormone, and possibly you can be on a very low dose of growth hormone, as I think Susan is, and take some Serovital to try to supplement it. They are different medicines, so they may have a different side effect profile. Susan also asks, I get horrible cramps, I have severe joint pain. What else can I do if my weight lipid profile is good? BBCT is good, but weight is not. Thoughts. Swimming. I think, people with joint pain, swimming is often quite helpful. And, it's a really excellent form of exercise. And, healthy, clean diet. There's some thoughts that the processed foods are pro-inflammatory and can lead to more joint pains. The, greener, leaner foods are often are less inflammatory. Omega-3s are usually beneficial for things like inflammatory, like joint pains, and omega-6s are detrimental. Susan also asked, what do you think about turmeric for inflammation? From what I've heard, I think it also can be good. So that would be another option for inflammation. Alicia asks, is cortisol being released in response to catecholamines from the theo or para that is functioning? I don't think so. Generally, those also the theos make catecholamines and doesn't make cortisol. Testing has shown elevated cortisol and norepinephrine and norepinephrine both. I think you have the norepinephrine and norepinephrine can be mildly elevated without theo. And certainly the cortisol can also be mildly elevated as well. Is the cortisol raising it? I don't think so. Looking for a connection. If there's one, I've noticed marked weight increase immediately after an episode. I'm not that familiar with the linkage between the two. I think they're two sort of separate axes that shouldn't really affect you together. You spoke about a particular diet that works best in growth hormone deficiency. Are you a supporter of paleo, low diet, high protein? I would say yes, I am. In general, I'm a supporter of mostly of vegetables and low carbs. And you should get a certain amount of protein in, such as with turkey and chicken and fish. Many go overboard. Yes, you don't need that much protein. I mainly push a high vegetable diet, and I have an article on my website called The Vegetable Revolution, where I talk about how beneficial vegetables are. How should one get fiber if you have gastroparesis? So there's both soluble fiber and insoluble fiber. So soluble fiber would be in things like pea soup. So I think somebody with gastroparesis could probably have like pea soup and lentils and stuff like that. They may not tolerate, the very fibrous insoluble fibers, but they should try to get in as much as they tolerate. The best medicine for gastroparesis is erythromycin. That's often quite helpful for people with it. Gastroparesis means your esophagus and stomach doesn't empty properly. If somebody is on a restricted diet for a long time because they don't have an appetite and feel full immediately, how should they adjust their diet when they're able to eat the amount they should eat? I think you want to be gradual. I think you want to, keep your calories, try to eat a lot of healthy foods. Once you're able to eat better, probably for women, stick it down to, about the 1,400 or so calories a day amount with, again, a lot of vegetables and fiber and some protein. Do you think long-term Cortif intake damages the stomach? I would say no, and in physiological doses. So if somebody's taking 20 milligrams of Cortif, it probably doesn't affect the stomach. I think the cortisol damage is on much higher doses, super physiological doses. What I think about soy and tempeh as protein, I think it's also an excellent choice for most people. Candidly, how do women with low growth hormone receptor best deal with low sex drive? I think, in women, libido is a complex factor that is definitely hormonal, but also has to do with hormones such as testosterone and estrogen. I would make sure your testosterone and estrogen are properly replaced, and those often help a lot. There is a new medicine for libido in women. I've heard good things about it. I haven't used it myself in any patients. but you know, among the advisory committee of the website Empower, EMPOWHER, I think there's a lot of articles on this new medicine for libido for women on that website, and there's several doctors, including the founder, who thinks it's an excellent medicine. How do you fight yeast wall and steroids? You know, I think you can take probiotics is probably the best choice for that. If you need to, you can be on the fungal antifungals. Bob asked, does normal free T3, low free T4, and low TSH present a need for T4 replacement? And I would say that is looking like a picture of central hypothyroidism, where you have damage to your pituitary, and those patients may need T4 replacement. You want to see if there's other pituitary hormones that are defective in this case, such as a low IGF-1 indicating growth hormone deficiency and low estrogen or testosterone. But in those patients that seem to fit that pattern, they do need thyroid hormone replacement. Janet asked, do you ever prescribe keto for a patient who needs Cortef and has recurrent yeast infections? You know, I don't really treat yeast infections per se. I think I usually leave that to the gynecologist, or primary doctor. And in general, I probably, you know, I don't think I would use necessarily, I don't think there would be contraindication to use keto, because keto blocks the cortisol production in somebody who's on Cortef, like Janet, is not making any cortisol themselves. So I don't think keto would have any effect of their own cortisol and shouldn't affect the cortisol they're just taking by pill. Frederick asked, how do you take cortisol if you feel worse on it than on prednisone? So I think it was Frederick that asked the question before, what's the best type to take? I would say in general, the best type is hydrocortisone, but it varies, and I use definitely in different patients, dexamethasone, prednisone, Solu-Cortef occasionally, Medrol. I have one patient on Medrol, so you definitely have to customize that to each patient. What is your typical prescription for oxytocin for patients who are deficient? It's usually, I think it's 24 milligrams per mil, and it's like 3 puffs twice a day. But the patient should ask me for that, and we should go over carefully whether they need oxytocin or not. Any other questions? Thank you so much for doing this, particularly tonight. Happy last night of Hanukkah. Happy Hanukkah to everybody. It's very helpful to get direct information this way. Okay, we'll ask for 2 more questions or so. Frederick says, what should you do if your testosterone affects your mood? You know, I presume that means that makes it worse, so you probably don't, you have to be either go on a lower dose, try a different delivery system for testosterone, or maybe it's not going to work for you. Okay, happy Hanukkah to you, and thank you very much for doing this webinar. I appreciate it. Thank you. Okay, we will call it an evening, and I'll post this on the website, and we'll have other webinars coming up. Thanks very much.